I'm Mark Kwan. In this episode, we will turn our focus to European region. Once again, we were treated with many high-caliber presentations. It was very difficult to choose from them. One of the presentations we will watch together today is titled Digital Workflow for Full Arch Rehabilitation, The Tips and Tricks by Dr. Darius Tomina from Romania. This presentation was excellent in many regards. It was well-structured, easy to follow, well-documented, and had up to 3 years of follow-ups, which is not easy to do. On top of that, the presenter conducted his own studies and analysis, which is exceptional. There was not much to critique with this one. Maybe a bit more styles in color contrast, in text, fonts, and slides for better viewing experience. But then again, these are minor points. Obviously, Darius has worked very hard and put a lot of time and effort on this presentation. Well, all of you are in for a treat. Hope you enjoy this one. Digital Workflow for Full Arch Rehabilitation, The Tips and Tricks by Dr. Darius Tomina.
Greetings everyone. I'm Dr. Darius Tomina from Romania, and I'm really happy to share with you my experience using the MegaGen dental implant system on this great opportunity of MegaMind 2023. In the past years, with emerging technologies and shifts from a conventional to a digital approach in implant dentistry, there were, and unfortunately still are, a lot of challenges to face for the daily practitioners. And what is the best way to move forward and evolve? Well, is to look back at what went well and what went wrong and establish ground rules in accordance to the latest technology, in accordance to the literature, and of course, in accordance to your own practice. This is the reason why, together with my colleagues, we conducted a study on more than 1,400 MegaGen Enrich implants, which were placed over a period of 5 years. Although the study is really comprehensive, taking all the factors we can think about in consideration, from implant planning to final prosthetic delivery and recall, bone reconstruction, soft tissue reconstruction, types of prostheses, biological and mechanical complications, we draw some major conclusions out of our work. It is nothing new, but we summarized all the factors that influence the long-term success of our implant therapy. So now we are talking facts, doubled by many studies, ours as well, and of course, doubled by our own experience. And we can say for sure that periodontally compromised patients, especially periodontitis stage 3 and 4, suffer from an advanced bone remodeling and resorption, even if the disease is stabilized and contained. Screw-retained implant restorations suffer a higher marginal bone resorption in comparison to the cemented ones, of course, if the latter are adequately managed. The abutment cuff height plays an important role in maintaining the platform switch concept and all the advantages that emerge from this concept. The submerging level of every submerged implant should be particularized for each case and not standardized at all. The lower the number of prosthetic procedures, the higher the chances for bone crest stability. And last, but not the least, the materials we use for our implant-supported restorations, especially the particular benefits of polished zirconia. Well, these are periodontal and prosthetic considerations of our work, but the biologic principles, like the 3D position of the implant type, the adequate bone housing, and soft tissue support should come first in order to create the perfect path for prosthetically loading the implant. Now, of course, all the data we collected were previously researched in hundreds and probably thousands of papers, but the literature can be somehow nowadays confusing and disruptive. Why? Well, because we can find articles saying opposing things on almost every subject we search. We should then rely our daily practices only on verified data, meta-analysis, and systematic reviews. Unfortunately, this data is still unavailable or is just emerging in the digital dentistry era. On the other hand, from a clinic perspective, the digital dentistry changed our lives in a way that we cannot go back. From single unit implant-supported restorations to full arch-supported surgical planning and restorations, the benefits are endless in terms of time, in terms of having all the information you need at a distance of a mouse click, in terms of less errors and materials consumption. It is amazing how you can see, for example, a model error right away without having to wait for a confirmation from the dental technician. So, having the conventional implant therapy experience and embracing the digital technology and knowledge, I started this journey 5 years ago. I'm going to present a proposed protocol with exemplification on one of my first cases I treated using the standardized procedures. Of course, it's been a long time since I started and I evolved a lot in the past years. The main advantage of the digital dentistry is that we can establish mathematically protocols because digital dentistry is mathematics. So the protocols I'm going to present today, it's a protocol that consists of 6 steps. Of course, these 6 steps go under the 3 main pillars of the implant dentistry. And what are those pillars? Well, the diagnostic, the surgical, and the restorative phase. So let's start with the diagnostic phase. In the digital dentistry, the diagnostic phase is the most important. If the diagnostic is correct, everything else falls in some Lego pieces that we can put together following certain rules. If the planning is correct, then the execution is something we just do. It can be done by a 60-year-old student, or it can be done by a 30-year-old experienced surgeon with the same outcome. The only difference is in terms of time, while the experienced surgeon will do it much slower due to the lack of confidence in technology. So why is it so important in the digital area? Because we have to take all the digital tools that digital dentistry provides us in order to be sure that we can create our virtual patient. Yes, we can create a virtual patient that has exactly the same particularities and exactly the same characteristics as the real ones. And how do we do that? Well, first of all, we have the digital photography. Second, we have the face scanners. We have the intraoral scanners and the powerful CBCTs. And all these devices will perform and will create images that we can afterwards merge in order to create the virtual patient I'm talking about. With this thought in mind, let's proceed to our patient. So, this is the way she presented to our clinic. She had an old removable prosthesis in the lateral maxilla with a fix. Actually, it used to be fixed in the frontal area. Now it's not fixed anymore. It's been a couple of years since it's not fixed, and this is her initial situation. It doesn't matter if everything is clear from the beginning of what we are going to do and how we are going to treat a case. We still have to collect all the information that we can collect from our patient. And why? Well, because we can use all the information in further stages in order to deliver proper restoration, in order to position some implants in a specific area, to maintain or alter the vertical dimension of occlusion, to proper plan the position of the incisal edge. And all of this will help us further on to deliver the best treatment, to offer the patient a restoration that he or she will feel comfortable right away. This is our patient relaxed lip position, and this is the CBCT scan. Well, none of her maxillary teeth can be saved. For this case in particular, I had a really big challenge. And what was the challenge? Well, the challenge was the angulation of the alveolar process, because we can see here that even though the roots are really inclined and they have a really bad oblique facing buccal axis, the alveolar process is following the same pattern. When we talked to our patient, she said that she definitely needs a fixed restoration. And of course, this was the case because with the angulation of the alveolar process, a removable one would have put a lot of tension and a lot of pressure in the upper lip. She also said that she hated her gummy smile for her entire life. And if she's doing surgery and if she's getting all her maxillary teeth pulled out, she wants to get rid of the gummy smile as well. So, in accordance to the clinical pictures, to the DICOM, the STLs that resulted from the intraoral scanning, I started to plan this case and I ended up proposing 6 implants for the maxilla. The patient didn't want to do any work on her mandible, so this is the reason why I didn't want to extend too much in the posterior with implant restoration prosthesis. This being the reason why the distal implants will be placed more mesial than they should be. And of course, this way sinus lift and bone augmentation procedures for the posterior maxilla will be avoided or were avoided. The planning was done with the RTGate software, which is a powerful software for collecting data and planning implant surgery or prosthesis. It is amazing how you can see and plan the implant position in accordance to the bone housing and the digital walks-up. For this case in particular, the freehand position of the implants would have been really challenging, and just for a really, really experienced surgeon. After the plan was done and checked, of course, and double-checked and triple-checked, we move forward to printing the surgical guide. This guide comes with a hard silicone occlusion key in order to fix it in an exact position in accordance to the lower teeth. After doing this, after doing all the planning and probably the hard work and the main work was already done, we can move forward to the second step of the protocol, which is the surgical protocol. By the time I treated this case, I didn't know anything about the stackable guides, and I did it the old way. Well, it's funny to call old recently new procedure that is already replaceable with a new, more innovative technique. And again, this is what digital dentistry can offer us: way much faster techniques and protocols development. After extracting all her maxillary frontal teeth, I place the surgical guide and move forward to placing the implants. This is a surgical guide fixed with 3 anchor pins on the maxilla, having a really, really good stability. A really important aspect for this case, and for every case in particular, if you are planning to use the proposed protocol, we need to leave as many superimposition points as possible in order to be able, further on, to virtually articulate the model with the initial situation. This is the reason why for this case, the tooth 27 was left in position and it was extracted right after the implant placement and the scanning of the implant position. Even though the implants were planned to be more submerged than they should have been, this was a flap surgery in order for me to be able to remodel the alveolar process and to surgically reduce the gummy smile that the patient complained about. This is the position of the implants right after the surgery. I managed to load 4 implants out of the 6 placed because the posterior implants didn't meet the criteria for immediate loading, which means that they didn't have a good enough insertion torque and a good enough ISQ value. Now, after the surgery, we can move forward. Right after the surgery, we can move forward to the restorative phase. Now, step 3 and 4 in our restorative phase represent collecting data again. And what does this data collection mean? Well, this means the scanning of the implant position with the help of the scan abutments. And you can see here the reason why we kept the tooth 27 in position, for having the proper occlusion and for having a fixed merging point. Now, after the implant scanning and the extraction of the tooth, we can advance and go to the designing and manufacturing of the provisional restorations. Actually, the design was made in the diagnostic phase and in the planning phase when we plan the implant position. Like I've told you before, that's the largest phase of all. We also plan the provisionals, but now in this step right here, we just have to superimpose and to match the digital prosthetic work to the actual clinical situation. This way, we are sure that we'll get rid of the little errors between the planning and the clinical outcome in order to deliver a passive restoration. We are talking digital right now. We are talking about designing with implant position, following the backwards theory that states that implantology is a prosthetic branch of dentistry which has a surgical component. After we do that, we can move forward to planning the zirconia abutments. And here we have the digital planning of the 4 zirconia abutments. Why do we use zirconia abutments? Well, because we have a perfect control of the platform connection. There are zirconia hybrid abutments, which means that we have the zirconia abutment, which is fixed on a standardized titanium base. Well, we have the perfect control of the platform connection and the standardized cuff height of the titanium base. And the most important thing, they are really biocompatible. They show the highest rate of fibroblast proliferation in the transition zone. The transition zone can be designed in order to maintain or create the perfect gingival architecture, and of course, after fixing them into the implant platform, they can be treated as natural tooth abutments. Also, really important aspect here, they prevent the appearances of gray shadows in time due to their color and their texture. And here is our patient with the provisional on the final definitive Restoria zirconia hybrid abutments. You can see the chlorhexidine stains, and these are the abutments with the provisional restorations delivered on the abutments. Here you have an occlusal view, and this is the CBCT for a checkup after the implant insertion and the provisional delivery. And we can see that everything went perfectly according to the planned situation. If we compare these images to the images from R2Gate, we can see that our implants are exactly where we wanted them to be. Now our patient is really happy, looking forward to get the posterior teeth as well with the final prosthetic restoration. The last step of the protocol represents the delivery of the final prosthetic after the proper soft tissue remodeling and healing, and this can be done digital as well. We just have to scan the implant position for the posterior implants left covered during the first surgery, and the zirconia abutments, of course. If the healing is not as good as expected and the gingival margin recedes on the zirconia abutments, we can just finish the line of the zirconia abutments using an extra fine zirconia burr. For this case, this was not necessary. I just used the scan plan make done protocol for the already in place zirconia abutments and implant position for the distal ones. And here is the final restoration with layered zirconia. The initial situation and the final restoration with a 3 years follow-up. And you can see here the stability of our implants, the stability of our restoration. And this is one of the many cases we treated this way, and all the follow-ups look really, really good, and we are really happy with it. Now, what are the main advantages for this protocol? The technique is reproducible, it is easy to execute and to manage complications. The total chair time for this patient was about 5 hours. And the disadvantage is, of course, the bad planning leads to bad results like everything in digital era. Having this in mind, I want to thank you very much, and I hope to see you in the next stages of the competition. Best regards.
The next contestant is relatively new to this implant game. Even though she's only been doing implantology for several years, her fundamental understanding of this discipline is very strong. The presentation title is Push Yourself Because No One Else Is Going to Do It For You. The case selection, documentation, and the case explanation was calm, steady, and very clear. She explained her case very clearly, and her photos and x-rays that were included were high quality. She kept the presentation simple, concise, allowing audience to easily follow her storytelling throughout this inspiring presentation. However, at the same time, being too concise was also the area of improvement. The presentation was less than 13 minutes. Perhaps adding more research support would have made this presentation even more outstanding. Overall, a great presentation from Dr. Nurchen Imas from Netherlands. I'm sure you will enjoy this presentation. Push yourself because no one else is going to do it for you. Enjoy.
Hi, my name is Nurchen Yilmaz, and I'm going to present a case for MegaGen MegaMind 2023. In 2019, I came in contact for the first time with MegaGen through Irfan Abbas. And in 2019, I did the course, and I started doing little by little since 2020 implantology in my own practice. Of course, I can't do this on my own, so I have a team around me. One of them is my sister. She does the orthodontic part and especially the general dentistry in the practice. And of course, I can't do this with myself and her. So I need a bunch of ladies around me, from a manager to girls that are skilled in implant surgery. So here you can see my team. And I got the chance in November 2019 to attend, after we've done the course in Holland, to attend a week long with this group, a practice in Tijuana, Mexico. We did there all kinds of surgeries, from bone augmentations to sinus elevations to implant dentistry. I even had to remove a bullet from a jaw. So we got luckily the first group that attended this Tijuana, Mexico experience. And there, of course, we learned a lot. Before that moment, I didn't implant myself in my practice. And so when we came back, unfortunately, it was already still during COVID. We knew that it would be a little bit difficult to start doing implantology in your own practice. But still, though, we had patients, and I got the chance that my major teacher, Irfan Abbas, took the time to attend 3 times with me in the practice to do some major cases, or sometimes the smaller cases, so I could improve my skills in implant dentistry or implantology. As I started, I needed to push myself to new boundaries, because this was a new chapter in my life, and I'm lucky that I got the chance, because I have such a good teacher. And when you have someone as a backbone, you aren't afraid to start doing it. So this lady, my case, presented herself. I guess she's 59 years old. In my practice, she was referred to me by another dentist, also an implantologist, but on some reason he didn't dare to do it. So he referred her to me. When she came in January 2022, the left lateral was already extracted. So this picture is one of the former ones. And this was her initial situation when she came to my practice. So as you can see, the left lateral was already extracted, and you can see some bone defects already, and the right lateral is still in place. As you could see on the Röntgen X-ray, both teeth already had the same situation. So we discussed this with the patient, made a CBCT just to have a look how big the inflammation on the right lateral was. And in order to do good implant dentistry, and for the fact that I was just skilled for 2 years, I didn't do this freehand. So I chose to do it guided through Artigate. So if I do guided dentistry, I make an intraoral scan and a CBCT scan. And as you can see on this picture, I plant the implants together with Artigate. And on the X-ray, you can already see that on the left lateral, there's less bone left than on the right lateral. So the day of the implant treatment, we decided to remove the right lateral as well. And there we could have done it flapless on the left side. Unfortunately, we needed to make a flap. So we did our flap design, but first before we did our flap design, I had to have a look if my guide would fit, because if my guide won't fit, the whole implant procedure will be biased. And then we have 2 kits. Since I planned, I already lost so much bone on the left lateral one. I had an implant kit for mini implants on the left one, and a normal kit, a guide kit with burrs for the right lateral one. So I used 2 kits of Megagen, and then step by step, as our guide is telling us, since we have learned this through the education, we could burr and place our implant. But before I place my implant and after my first initial drill, I always want to make an X-ray just to have a look if I'm in the right direction. Since I'm not an experienced implantologist, these are steps for me to build in just to make sure that the things that I'm doing are correct. So eventually, after all those steps, on the right till the right diameter, we place our implant. And as you can see, we could do this one flapless. We place the implant, and through specific screws, as you can see here, you must place the implant exactly correctly with that gold stripe you can see and the black one, since afterwards we are going to place a temporary crown on it, or we screw a temporary crown on it. And if those collar and the gap don't fit, then the temporary crown won't fit in its place as well. So you need to be very careful while doing this. And then during the treatment, after I've placed the implants, I always do an ISQ meet. I use my ISQ meter and I do the measurements just to be sure if I can load it. Of course, the crown is out of articulation and out of occlusion. So just to be sure, I do the ISQ measurement and know how big it is. I guess both were around 60, not ideally, but enough for me to place the temporary crown or screw the temporary crown. As you can see, this one was done flapless. And the other one, unfortunately, we need to do a flap, but I just made it loose and made an envelope and placed my crown, just 2 stitches, and sent the patient away. And after 2 weeks, this is the initial 1 week, I guess. 1 week, 10 days. No, after 10 days, I removed 10 to 14 days, I removed the stitches. So this post-op situation is after 2 weeks. And as you can see, that it's healing very, very good. And after the placement, as you can see, the Teflon tape is still in it. I make an X-ray just to have a look if it's good. On the X-ray, you can see that we used on the left side a mini implant, and on the right side, we used a 3.5 diameter. On the right side, it was 13 millimeter, and on the left side, it was 11.5 millimeter. So after 4 months, the patient came back for the definitive crown on implants. And this was the initial situation after removing the temporary ones. And as you can see, in the delayed situation, you can see that we lost much more bone than we really want to. And on the right side, you can see that the bundle bone is still enough. Or it looks, at least we know that aesthetically it looks better than on the left side. In this case, you could think about a mucogingival graft, but as you will see further on, she doesn't show anything of her gum or gum smile in the picture while laughing, so we didn't do it. As I said, I use the MEDIT scanner, and the MEDIT scanner you can use together with the scan abutment when you're going to make the definitive crowns on it. And as you can see on the right side in the lower, in the picture, you can see that's the scan abutment. And after I've placed the scan abutment, I always make X-rays just to know for sure that I can see if they fit properly, because if they don't fit properly, then the scanning will also be wrong. And then afterwards, you will see that the crowns won't be in place or won't come in place, and then you need to redo it. And that's the positive thing about Megagen, that you can also X-ray the scan abutment. Here you can see from a closer view that on the left side we lost much more bone because of the delayed situation, and on the right side, okay, we lost some bone, but still less than on the left side. Here you see the post-op situation after directly after placement of the definitive crowns. And I always make 2 X-rays after placing them, just to have just to be sure that they fit in place. And then 9 months post-op. Unfortunately, I don't have any post-ops from 1 year yet. So I'm going to share the 9 months post-op pictures with you. And as you can see, it's a quite quiet situation. No bad things, just a small gum irritation on the right lateral. I did my measurements with the probing, but there was nothing strange to see. So I gave her some Blue M oral gel just to heal it. I advised her to put it on 2 times a day. And here you can see very, very good from a closer point of view that we lost on the left side more bone, and that the gums look, a little less aesthetic than on the right side. And from this angle, you can even see it better. So what I've learned from this case is if you're going to send patients to a colleague or someone is referring patients to you and they do have this implant wish, then at least advise them not to extract a tooth and make that decision yourself as an implantologist. And here in the end picture, you can see that while she's laughing, you can't see anything of her gums. So we accepted not to do the mucogingival graft. She's not disturbed by it, and I think this is quite a nice aesthetic end result for this case. Thank you very much for listening to it, and have a nice day.
Those who are joining me live, we appreciate your support. And those who cannot, these presentations are 15 minutes long and will be available on our website, globalmegamind.com. Unlock your potential, test your mind. We are Megamind.